Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to this week's episode of the Codecast podcast. My name is Terry Fletcher, and I guess I should say Happy New Year. We're into 2019 now, and so we're very excited to have you with us on the air. Over 30,000 listens, so we're pretty happy with how things are going. Our topic today is we're going to talk about new versus established patient, and then some of the quirks that go with that. So understanding what that means from preventative medicine and also sick appointments. So when we get into the problem-oriented visits. And I'm also going to talk about that when it means as far as what residents do in collaboration with the physician, and the 2 midnight rule, and then also the decision tree that you find in the CPT book, their version versus what the payers will pay. So you would think this would be an easy question. New versus established patient should just be somebody you've never seen before versus somebody you have. But it isn't. There's so many more quirks and little, anomalies and just, opinions and interpretations of the rule itself, and there's a big reimbursement impact as well. So we need to take a look at it, revisit it. I talked about it about a year ago, maybe at the beginning of 2018. And so I just want to revisit it as we're getting into 2019, especially now since, Medicare and some of the third-party payers, especially CMS, is really starting to add some things to our E&M, which are our evaluation management services, and just talking about what we can do in that realm. And that's really, where our money is, unless you are a surgeon. So a surgeon has the large ticket items, but the medical physicians that spend so much time doing diagnostic tests and, visit codes and consults and things like that, your bread and butter is about these E&M services and visits and new and established patients. If you don't get it right, you're going to lose a lot of revenue. So we really want to talk about that. I want to give you some insight there so that you're not losing revenue and you're choosing the right code. And then understanding from an auditing perspective, what you'd be in for should things be looked at. So we're going to kind of talk about that today. But first, the Codecast podcast is brought to you by Movado Watch Company. Movado, one of the world's leading watchmakers. Movado, modern ahead of its time, Movado.com. And Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. HealthcareExecutivesNetwork.org. Okay, so first I wanted to start with what the CPT book says about new versus established patient. And if you have a CPT book, which is the current procedural terminology, that's the code book that we all use. That's the kind of the riff on the Codecast podcast. But that's the code book that we use when it comes to submitting claims. So everything that a physician does is tied to a 5-digit code, which is a CPT code. And then it has a link to what we call an ICD-10 code, which is a diagnosis code. And then we submit it on a claim form, which is a HCFA form, to a payer, either electronically or, God forbid, by paper anymore. And we basically hope to get paid for it or expect to get paid for it based on what the coverages are. So what CPT says, and they put it in their let's see, where are we at? In their evaluation management services on page 4, it says new versus established patients solely for the purposes of distinguishing between new and established patients. Professional services are those face-to-face services rendered by the physician and other qualified healthcare professionals who may report evaluation management services reported by a specific CPT code. Okay, so professional services, that's what the physician bills. Okay, you're not a facility, so you're a physician, so you bill professional services. And then it goes on to say a new patient is one who has not received any professional services from the physician or qualified healthcare professional or another physician or qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. So I need to stop there for a second. Well, they added the word exact same and subspecialty to the text a couple of years ago, and that's kind of messed people up a little bit, because then it goes on to say an established patient is one who has received professional services, again, doctor services, from the physician or qualified healthcare professional or another physician or qualified healthcare professional of the exact, there's that word again, same specialty and subspecialty, who belongs to the same group practice within the past 3 years. See decision tree. So the decision tree is on page 5 in your CPT book when you go back to reference it. But what's interesting here is, first of all, there's a 3-year rule. So if your doctor, as a rule, has not seen a patient or an existing patient in 3 years, you have met the criteria for a new patient visit. So that's the first thing. But there's other things and variables that are something you have to take a look at. And one of those variables talks about the exact same specialty. And what's interesting is when they talk about the decision tree. Now, the decision tree drives me crazy because the decision tree basically reminds me of something I used to actually kind of argue with my husband about, which was I would come home from a business trip and he'd be like, "Did you close the garage door?" And I'd be like, "Yeah." "Are you sure?" "Yes, I'm sure I closed it." Okay. So I'd go and take my bag and put it in the bedroom, and I'd go put my briefcase in my office. And all of a sudden he's like, "Did you close the garage door?" I'm like, "Yes, I told you I did." And he's like, "Okay, just double checking." I said, "No, that's triple checking." Well, then of course, when somebody kind of questions you a couple of times, because maybe you forgot at some point, not mentioning any names, but at that point you basically go back and you're like, "Okay, let me go check," because now you question, did you actually close the garage doors? So what they do in the decision tree in CPT just reminds me of that. Here's what you're supposed to ask the question. So was the patient seen for services by the physician or a member of your practice in the past 3 years? Well, if the patient says no, and you're addressing the patient in this question, then obviously it's a new patient. But if they say yes, you don't automatically go to an established patient. Then you say, were you seen by the physician of the exact same specialty? And the patient's thinking, yes. And they're like, okay, the exact same subspecialty. Got a little tongue-tied there. And the patient's thinking, I don't know what you're asking me at this point. So this is where they're almost goading you into basically coding a new patient visit. So let's talk about that. Well, we have something in Medicare called Taxonomy Codes. And what that means is that a physician has a designated 2-digit code that they would input from when they sign up with Medicare as a provider. And it's basically, so if you're cardiology, it's O3, but if you are interventional cardiology, it's C3. So something like that. So when they look at your code, they're basically saying, okay, well, this is what type of physician you are. But what if you're electrophysiology? That's a subspecialty in a different taxonomy code, just like we just talked about interventional radiology, but that actually is an alphanumeric code, so that's a different story altogether. But think about orthopedic. Your general orthopedic, you could be foot and ankle, you could be spine, you could be hand surgeon. What is specific to, that? Is that the exact same specialty or subspecialty? So there's a couple arguments to be made here, and I've made them at several practices that I not only audit for, but that I'm brought in on practice management situation. Taxonomy codes being separate, that's easy. So if you just pick on cardiology for a second, if you have general cardiology and then electrophysiology, general cardiology deals with blood flow and blockages and coronary artery disease and congestive heart failure and things like that. When you're dealing with electrophysiology, you're dealing with the computer of the heart. So now, even though there are congestive heart failure issues, now you're dealing with is the computer of the heart rebooting? Does it need a pacemaker? Does it need a implantable cardiodefibrillator? Just totally different branch of the cardiology specialties. So if a patient sees a general cardiologist and then sees an electrophysiologist, can they get us a new patient visit out of that? The answer is yes, 90% of the time, unless the initial physician basically transferred them for a pacemaker, which they never do. They're basically saying, we found an arrhythmia, or we see an abnormality that you need to go see our EP doc, or they call them in for a consult, and then that would be new. And then they want them to figure out what's wrong with them. Same with ortho, for example. You've got a general orthopedic physician. They got a patient who's complaining of chronic low back pain. General orthopods do not do spine surgery. So now this doesn't necessarily have a separate taxonomy code, but it is a separate subspecialty. So same with, hand has a separate taxonomy code, foot and ankle doesn't. So see how you have to look at it from the spirit of the rules. It didn't say anything about taxonomy codes in the CPT book. That's a Medicare nuance, like incident 2. And so you want to really understand that and I've brought this up before, if you can make an argument for support upon appeal, if you're going to bill something some way based on your interpretation of the rules, go for it. As long as you can make an argument on appeal that you are above board doing what you're supposed to do, then I don't see any reason why you shouldn't attempt it as long as you can support it. And so when you have those separate specialties or separate subspecialties, whether it be from a different taxonomy or not, then you should be able to basically say, okay, I'm going to capture that as a new patient visit because this patient isn't being transferred for a procedure where the history and the exam's already done and the medical decision-making's done, basically. And so that second physician of a different specialty now is just taking over care. This is a patient who presented with a problem that the first physician needed to consult or bring in the second physician, basically for the patient to get worked up again and make their determination on what that patient needs. And that's really what you're looking at here. Did that second physician's expertise, was that required to then work the patient up again to determine what they need for care and ongoing treatment? But here's where some problems lie when it comes to new and established. I noticed that some practices basically say, okay, well, I haven't seen the patient in a year and I don't really remember them, so I'm going to work them up again, and that's new. There's a 3-year rule, so you have to hit that 3-year rule. Second, I'll have some practices saying, well, I do sports medicine, so I'm, let's say they're orthopedic. I'm a general orthopedic physician, but I also do sports medicine. So I focus on knees and shoulders and injuries. Okay, well, so do general orthopedic physicians. That's not really considered a separate specialty unless you dedicate your practice to professional athletes. Same with if you are a physician, let's say in cardiology, that does peripheral vascular. Well, there is peripheral vascular taxonomy as far as a subspecialty, but that's if you're doing peripheral vascular or what we call peripheral cardiology, just as a cardiologist, it's such a small carve out of interventional radiology, unless you're saying that at least, 80 to 85% of your practice, again, what you can support, improve, is really dedicated just to the non-coronary patient, and you're a cardiologist, you'd have to explain that, then you really can't, if it is, then you can go ahead and try to get that new patient visit. If it isn't, then I would basically call it a transfer of care, and that would be established patient visit. There's some gray area here, there's no question. And if you're unsure, go back to your definition in CPT and then look at also what Medicare says about it, and that'll probably help you out as well. So another thing I wanted to take a look at when it comes to payment policies for new and established is when we're looking at preventive medicine codes. Some patients sometimes will come in for a new patient office visit and they're saying, why I'm here, can you also do my annual? And I look at that and I think, okay, you should say, you know what, today is just your problem-oriented visit. We're not going to do a PAP today, or we're not going to just do your physical exam. And the reason is that there are certain elements of the preventative medicine exam that are duplicated in the E&M visit or home visits even. And these certain elements, they include vitals and, certain portions of the history and really the preparation and the information that you do in the exam. It's not the welcome to Medicare visit. That's just basically an inventory. But that's why I see a lot of offices and a lot of practices, they're really trying to split and get, the 25 modifier, let's say, on the E&M service, the problem-oriented visit, on the same day as the age-appropriate preventative visit. And so they're trying to put that, 25 modifier on it and saying we should get 100% of both. And a lot of payers now are saying you're going to get 50% to the problem-focused visit because we're only going to pay you of the E&M, we're only going to pay you 100% of the preventative. So the reimbursement of the preventative, will basically be paid first, which is usually lower, and then they'll give you 50% of the problem-oriented visit. So really be careful with that, with those split visits, just because of how much duplication is, part of that visit. And then I mentioned when we talk about the teaching physician and the residents. So when I see this a lot of times, what I see from an auditing perspective is documentation by the resident that says that the teaching physician was present and they were participating in the care. That's really not sufficient enough to establish, the participation and presence of that teaching physician just because they say they're there. What I look at on medical review is the combined entries into the medical record by the teaching physician and the resident. That's what constitutes the documentation of the service, and together that supports the medical necessity of the service. So there needs to be both situations and both services that are part of that. Otherwise, it's really you're kind of asking for trouble. So try to be careful with that, especially when you're dealing with new and established patient visits. And then I wanted to talk about the 2 midnight rule. But first, I wanted to thank Simple Health Radio, discussing topics related to your health and well-being, simplehealthradio.com. So the two midnight rule, and I mentioned this before, what this means is that, so in 2013, Medicare put a final rule in place that basically said for a patient to be considered an inpatient, there had to be appropriateness for the patient to require to stay that crosses at least 2 midnights. And so that they talk about the beneficiary. And if there wasn't within that documented record a determination that the patient really had that expectation of staying past 2 midnights, then it really wasn't reasonable to code as a inpatient service from a place of service perspective, that basically it was going to be now an outpatient short stay. And so just make sure that your physician understands that this was given back to them as far as the power to make this determination. It's always been made by the facility, which means that they're going to get their capitated rate for any kind of the short stay, because they're now going to get this, when you're in a short stay, you get a rate of about 8,000 to 10,000. But when you are now in an inpatient admission, you're now in a per diem, because now they count days and it's so much lower. So it's really about money, unfortunately. But here's what you just need to remind your physicians. The decision to admit a patient as an inpatient, it's a complex medical decision, and they're the ones that get to make it. And they need to make sure that they can support the reasonable and necessary factors, that the expectation of the duration of the stay has to exceed 2 midnights. And this should include an appropriate medical history, any comorbidities, severity of sign or symptoms, current medical needs. Maybe the patient needs to be on IV diuretics. And then the risk, and this is the big one, the risk of an adverse event during the time period of hospitalization if they are discharged before the 2 midnights pass. And there's usually a certification form somewhere on the nurse's station. And so that's a really big deal. You just want to make sure that you have that information. Otherwise, it can be, a real tough thing. And what'll happen is that, let's say you're doing a procedure and you bill it out as outpatient, or let's say even inpatient, and your doctor told you that it was in or outpatient, and the hospital doesn't agree because your doctor didn't certify as an inpatient. So you just have to understand that these are carrier driven, but now your doctor gets to really make the decision if a patient is in or outpatient, not the facility. Now, if your doctor doesn't certify the stay, then yes, the facility jumps in and says, oh my gosh, this is outpatient. They love to do that. But the other thing, keep in mind that let's say your patient needs to be transferred to skilled nursing. Well, if they're not in at least 3 days, then they don't qualify for skilled nursing from a payment perspective. Their reimbursement now goes down to the skilled nursing facility or long-term care goes down to 50%. And a lot of times their secondary doesn't pick that up. So some of these issues are very far-reaching, and we just want to make sure we're protecting the patient as well as our practice and what we can do whenever possible. Okay, so we have a coding question today that came in recently. And somebody asked, so Terry, when my doctor puts a lengthy discussion with patient about smoking and the need to quit smoking, and we did offered a prescription for a Chantix, and the patient is a current smoker, can we go ahead and add that 99406 code to the claim that also includes a E&M service? And I'm like, well, sort of, only if there's also time. Remember, the 99406 has 3 to 10 minutes, and you need to make sure that you specify in between that 3 to 10 minutes. So something like 5 minutes spent with the patient discussing the need for smoking cessation, and we gave them a prescription of. So something like that. And if you don't put time, lengthy discussion means nothing. If it's a time-based code and they actually give you the time range in CPT, then you have to come up with an exact time within that range. If you don't, then it's just very nice of you. It's very free and you can't add anything else. So we thank my listener for that question, but that's pretty important. And the one thing about smoking cessation, I always look at this as, revenue opportunity if you're doing it. There's no copay or deductible tied to that anymore if it's a current smoker by Medicare. And so they used to put the share of cost in there, but there isn't anymore. They're really trying to get physicians to have that conversation with the patient and hold them accountable as well for their healthcare choices. So hopefully you'll kind of bounce on that and just really give some information to your physicians as what's appropriate. Okay, and then the last part, and I know hopefully everybody had a good New Year, and this will actually drop on New Year's Day, so hopefully you're waking up early this morning, you're drinking your orange juice and your coffee, and you're like, I'll just listen to Terry today. I'm sure you're not doing that, but if you are, good morning. If you're not and you're later in the week when you get back to work, hopefully you had a great holiday season, and just a little personal anecdote for me. So one thing I like to do is on New Year's Eve, I'm not a big going out to parties or anything like that. I personally, because I don't want to be on the road, and I'm sure some of you can relate to that. So I'm big on having some wine, and I like reds, and so basically and watching a great movie. And usually it's something that I've seen before, but just something that, kind of is familiar and everything. So my movie that I got to watch was basically, it was a Christmas movie that I hadn't seen in a while, and it's called The Ref by Dennis Leary. For any of you that have a cynical sense of humor, you want to rent it. It's a pretty funny movie. So it has Dennis Leary and Kevin Spacey in it. It's pretty funny. So that's just my recommendation for the week. And I don't watch many movies, but when I do, I like some of the things from the 80s and early 90s, or, just some of the older movies. I just love the time period. It's just, you can tell how, I don't know, makes me feel good about where we're at now electronically and technology wise. And I like those movies that they didn't have cell phones, or they look like huge bricks, or, they had to rely on what they actually instinctively knew. So anyway, it was just, you see people running to the telephone because it's on the wall at home instead of always in their pocket or in their hand. So anyway, that was my recommendation for the week, and I hope everybody finds it funny if you actually go watch it. So everybody, make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.